Welcome to the Expert Roundtable podcast, where we connect frontline clinicians with top thought leaders to facilitate discussion on key issues they face daily.
Today's podcast will focus on relapsing multiple sclerosis with Doctors Robert Bermel, Fred Lublin, and Robert Naismith. Would you like to introduce yourselves?
Sure. Thanks so much, Mona. My name's Rob Bermel. I'm a neurologist and director of the Mellon Center for Multiple Sclerosis here at Cleveland Clinic. We're a large multidisciplinary MS care center located in Cleveland, Ohio, but with caregivers in Florida and in Nevada as well.
Thanks so much. Dr. Fred Lublin.
Hi, I'm the Saunders Founding Professor of Neurology and Director of the Corinne Goldsmith Dickinson Center for Multiple Sclerosis at the Icahn School of Medicine at Mount Sinai in New York City. I've been working in the area of multiple sclerosis for the past 40 plus years. I'm involved in many clinical trials, development of diagnostic guidelines, and in multiple sclerosis clinical courses.
Thanks so much. And Dr. Robert Naismith.
Yeah, welcome to the podcast. I'm Dr. Robert Naismith. I'm a professor of neurology at Washington University in St. Louis, Missouri, and I am the clinic director and director of clinical trials at the John L. Trotter MS Center.
Thank you so much for joining us today. Our topic for today's call is a discussion on emerging therapeutic targets for the treatment of relapsing multiple sclerosis. And I had a couple of general questions that I wanted to start with. And if we could just start with sort of a discussion on what are some of the mechanisms of MS that are being targeted by some of the emerging therapies and therapies in development, and what do you think may be some of the most promising in the clinical setting? And then how do you envision, if you could look into the future, how do you envision treatment of MS being different in the future, whether that be through various different mechanisms or delivery systems? And just to get your thoughts on where you think things are going. And if Dr. Bermel, if you'd like to get us started.
Sure. So really interesting topic. I feel like we've come a really long way in MS therapeutics over the years. MS in some ways is the example out there for all neurological disorders, for having identified outcome measures for clinical trials, how to conduct clinical trials in MS. And that's gotten us like tremendous progress. And we can in good conscience sort of sit in an exam room with most patients these days and tell them, we're not going to let them end up in a wheelchair if this is identified early and if they stick with us. That's amazing progress, but it's also given us a framework on which to build future progress. So all that experience that we gained in clinical trial design and expertise and in the development of things like imaging outcomes and biomarkers, I think we're going to leverage to take this even to the next level. In my view, the greatest unmet need out there is progressive MS and this concept of progression independent of relapse activity. When I, really am stuck with a patient, it's often that's the issue. It's that they're getting inexorably worse despite being on some of our best anti-inflammatory medications. And it's often not a rapid worsening, but it's a year by year, and the patient in their mind extrapolates, hey, like if I'm getting this little bit worse each year, what am I going to look like in 20 years? Something like this. And that's a really scary thing for patients and for us. And so the whole field of MS, the sort of the research, benchtop research, clinical trials, research dollars are all really, in my view, shifting toward progressive MS. And I tend to talk to people about a few different things. The first of which are a class of therapies called the BTK inhibitors, Bruton's tyrosine kinase inhibitor, oral therapies that initially were developed for certain oncology purposes and now being repurposed in autoimmune disease, including multiple development programs, multiple sclerosis, and one of which, tolobrutinib, may be the closest to being the next disease-modifying therapy that we see get some regulatory considerations for MS. The mechanisms involved in PIRA, progression independent of relapse activity, are likely multiple and they're not well understood. And it's likely a completely different molecular and immunologic ballgame than we've been playing in relapsing MS. And so mechanisms that impact things like microglial activation. Maybe we have a theory that that might be important, and that might be one potential target of agents like the BTK inhibitors. But I think drugs of that mechanism, for instance, represent, in my view, sort of one attempt to try to modify a type of progressive MS biology that we don't fully understand yet, but there's a huge unmet need for patients. And I think there's multiple other strategies, but I'd love to hear what my colleagues think.
So I agree that our proximate unmet need is better control of progressive disease, as Rob Bermel has outlined in the approaches that we're taking, which involves trying to get agents into the central nervous system to have a more targeted effect and hopefully maybe even a more durable effect. Things like CAR T therapy, yet to be proved, but if it has a more durable effect, in addition to a deeper penetration, that could potentially be a benefit. The other area that I think has not exploded yet, but is very potentially exciting, is repair of the damaged central nervous system. At this point, remyelination until we figure out how to regrow central nervous system neurons and synapses. There's some early phase work that's been done on this that has unearthed important insights in their failures, part of which that repair is at least one and maybe many orders of magnitude much more difficult to design studies around and to accomplish than what we've done with reducing, say, relapse rates. But the techniques are kind of coming along. With each study, we get a little smarter, but I think that's going to be a very interesting horizon for us. And when we accomplish that, it may well translate into other areas of neurodegeneration.
I think one of the major paradigm shifts in recent years is to better understand the neurobiology of the disease and how that differentiates itself from sort of the clinical phenotypes. So this idea that progressive begins at the beginning, and that there's this clinical lag, and that we need to come up with therapeutic strategies that address each of the modifiable components of the MS pathophysiology. That is the acute lesions working at the blood-brain barrier, prevent relapses and new lesions, at the chronic active lesions within the central nervous system, types of whatever we can with T cells, B cells, microglia, astrocytes, complement, and then the neurodegenerative process, which is born out of both the acute and the chronic lesions. And as Dr. Lubman said, the potential for repair, and to implement that at a stage where you have the best benefit. So I think one of the things that we're trying to contend with is how to identify these high-risk progressive patients at a stage where you can have the greatest window of therapeutic intervention. Because I think the field has lagged in identifying the progressive patient to sort of a stage later in disease where there's probably a lot of damage that's already occurred. So I think one of the notions is to try to, as a field, figure out, how to get patients into such studies earlier and how to measure their outcomes in a meaningful way, because this is a very tricky area, because you don't always have the clinical correlate of foreseeably altering some of these neuropathologies. But I think sort of in the future, we're going to have some better clarification as to how the B cell therapeutics are optimized. In particular, there's going to be a trial coming up very soon looking at double and triple dose ocrelizumab in progressive MS. This is getting at the notion that, perhaps a higher dose is required to get across the blood-brain barrier and may have a better impact on progressive disease. The relapsing study from the top-line results did not show an improvement in disability, but these are patients that don't have very high disability progression levels in the first place. So I think the high-dose ocrelizumab study will give us better clarity in terms of whether there's any differences among the B-cell depleters in reference to progression specifically. Another hot topic is CAR T cells. And this is looking at a variety of ways to approach B cell depletion with trafficking within the central nervous system. So these can target, the CD19, CD20, and the plasma cells by a variety of different mechanisms that could be built into these engineered T cells. And again, because these traffic across the CNS, the idea is that they wouldn't be excluded like the monoclonal antibodies would, but would get to the site of action and be able to influence the inflammatory response within lesions, the normal frame white matter, and the meninges. So I think these will be very interesting to kind of learn the extent to which the B cells drive CNS inflammation. A lot of the more recent concepts is the role of CNS-bound inflammation, particularly with microglia, astrocytes, and how they interact with B cells and T cells. So that's how we were hearing about the BTK inhibitors, and there's a number of studies that are going to be emerging with some initial early results that look very interesting, and it may change the way we approach our therapeutic strategies in clinic, but a lot more data to be generated in the short term. And also, like with CD40 ligand antibodies, this works at the interaction of the T cell and B cell, but also many of the cytokines and cell signaling pathways that have effects on microglia and chronic inflammation can be impacted by these type of approaches. So I think, certainly we want to have neuroprotective strategies and reparative strategies, and there are some treatments emerging for those that are in early investigation, but I think sort of where the field is moving is optimizing the B cell depletion approach by the ways that I just mentioned, and then also to what extent do the microglia result in a negative inflammatory state that is leading to ongoing slow neurodegeneration, axonal damage.
Yeah. So, Rob and Fred, I get questions from patients all the time about a couple of common topics. It seems like one is stem cell therapy, and that's just sort of like a buzz phrase, I guess, that is on the tip of unwind that and explain, that actually we are working with cell-based therapies, especially CAR T and MS, which, in our experience in the early clinical trials here has been very well tolerated, and we hope holds better therapeutic potential for CNS and tissue depletion as well as duration of action. We've had some experience with autologous hematopoietic stem cell transplantation for, patients with extremely severe MS early on, if we can select them appropriately. And I try to explain that is an extremely risky strategy where, we basically bring a patient into the hospital for 6 weeks and wipe out their immune system with potent chemotherapy similar to a bone marrow transplant, then rescue them with a newly transplanted immune system from their own stem cells. That's for a very, very small sliver of MS, but I think it helps to show that, the immune-based therapies, I think, is the right category for us to be working in. That being said, the other category that I get commonly asked about is repair. Or can't you just put the myelin back on the nerves? And I try to give people hope for that because I do believe that we're probably 5 to 10 years out from very reasonable remyelinating or repair trials. And in the meantime, we have to keep people, in my view, as neurologically intact as possible. And that means getting them on reliable and potent immunomodulatory therapy to control the active inflammation as best we can, so that when those repair strategies do come out, the patient is in as good a shape as possible and eligible for them, and that they have some axons to remyelinate. So those are some of the common questions I get, and I think they somehow connect to what we all just discussed, which is kind of the portfolio of things that are in the pipelines. But it's not immediately apparent, I don't think, to patients how they connect, and it's often up to neurologists, I think, to connect those dots for people. I don't know if you guys receive common similar questions or other questions from patients or referring providers?
Yeah, I agree. We do. The one that I think is most interesting is a mesenchymal or neurally directed mesenchymal stem cell therapies for repair, which is a very interesting strategy, but it is in its infancy right now. I, in fact, tell patients that anything you have to pay for is probably fraud. But there are some studies underway. They're just complicated studies.
Yeah, I mean, we did a trial in 30 individuals of autologous single-dose mesenchymal stem cells. And I think that's a great example, Fred, of what you just said, is it's in its infancy. We did not see any Lazarus effects with that. So most of the patients had some small subjective thing that they thought was improved, but we couldn't objectively measure any improvements. That being said, that was one strategy. There's multiple different variables in terms of how many infusions, what's the dose of cells, where do you get the cells from, how do you culture them, do you freeze them or not? I think there are many experiments yet to do to try to figure this out. It's still in its infancy. There's hope there, but we're early on.
I think, what's going to be interesting is a multi-pronged approach to MS treatment. We've really been well served by anti-inflammatory strategies that really work at the blood-brain barrier to reduce relapses and new lesions. But sort of, I think the next phase is going to be the sequencing and the combination of different strategies that are going to be safe or effective, and to sort of try to figure out who's going to be the best eligible people to have that benefit. I think with different mechanisms being targeted, this is going to be the big question in our practice for 2026 is how do you decide whether to need one versus another. Hopefully we'll have trials in the future of combination and sequencing to help guide us and to give people data on efficacy and safety. These are so early that we at this stage just have trials versus a single comparator placebo without really strategizing kind of all we do in clinic in terms of sequencing and foreseeably combining. But MS has multiple pathologies and multiple targets, and we certainly have leveraged the T cells and the B cells with 20 plus medications. But I think what's going to be very interesting is sort of the newer therapies and how they could be combined or used after some sort of induction of anti-inflammatory suppression.
So we can't have one of the foremost experts in combination therapy on the call with us and not ask Dr. Lublin what he thinks about the prospect of combination therapy. I don't know if it gives you shivers after the many years of the CombiRx trial that you ran.
Well, I think that the CombiRx actually has served us very well as a database.
For sure.
But the field has advanced well ahead of the agents that we looked at in CombiRx. Right now, the best strategy I would see moving forward for a combination would be adding a neuroprotective agent, which I don't have one yet, onto a anti-inflammatory agent, rather than doubling up on any inflammatory effects, because our relapse rate is so low, it's just going to be impossible to show any improvement over that. It's also possible that we can have a more targeted anti-progression agent that would be added on, but that might be a little more challenging than a neuroprotective because of the combined immunosuppression that it could produce.
Very similar to how I think many of us are thinking about it here as well.
I would say, we really need to help the patients to these trials because, like at our center, we have over 24 open studies and probably 5 or 6 that are currently enrolling. And we see thousands of patients, but we probably have just several hundred in these trials. And they're challenging to do. They really require a commitment on behalf of the patient to do it, but we need to study these in patients to show that they're beneficial. And it's becoming more challenging because sort of the standard of care has shifted so that, some of these trials are going to be difficult to power. So for example, with ocrelizumab approved for primary progressive MS, that makes the PPMS study a little bit more challenging. If tolebrutinib gets approved for non-relapsing MS, that's going to make that disease subtype more challenging to devise. So I think it's exciting that we're getting some progress in the clinical sphere, and we're very thankful and appreciative of the patient contribution of being in these trials. I have patients that have been in trials for over 12 years, and it's great to work with people. And of course, it's a commitment, and people need to work and their families, so not everyone can participate. But I'm very optimistic about the future of clinical trials in MS, because there just seems to be more every year. I try to make it a point to discuss with the patient when I get back from a conference, like, what did I hear that was exciting? Because I think for them, they don't get a lot of new news, because really the news that they get is a new therapy approval, and those are relatively infrequent. So I always try to tell them a little bit about what the conferences are conveying and what is kind of up and coming. I think that people are always interested to hear about that. And again, we need patients to help us find new therapeutics.
Thanks so much for sharing your expert insights with us on these important topics for the treatment of RMS. And thanks to our audience for tuning in. We hope you found this podcast to be valuable for your practice, and we look forward to having you join us next time.